Hello and welcome to this ERS Summit on Digital Respiratory Medicine, Realism versus Futurism. The aim of the summit is to understand where we are now, to learn the lessons from the last year and the digital transformation, and to understand where we're going to in the future. This summit is for everyone in respiratory medicine, all the members of the respiratory team and our patients too, because this is an adventure we're following together in partnership. So what will we be covering? Well, the plan for the next 2 days is to talk about what we've learned from the digital acceleration in the last year or so, to evaluate digital resources, to understand their integration in current pathways and new pathways, and importantly to cover areas such as access of all our patients to these resources and equity, and for that reason we'll touch on the relevance of digital respiratory medicine in low and high resource settings. So just to cover some of the themes that we'll be touching on. As we all know, I can't think of there's a single member who's watching who has not been involved in digital consultations over the last year. The Friends of Europe recent report has estimated that in Germany there has been a 10-fold increase in digital consultations or virtual management of patients, and in France that's 50-fold. Some data from the UK that you can see here in the top left. This shows outpatient consultations. In blue are the face-to-face consultations. Light blue is the first attendances, dark blue is the follow-up. And you can see that 2/3 of the way along that chart there is an increase in the red bars, which are the virtual consultations. So these are teleconsultations or video consultations, and you can see that as they increase, there was in fact an overall drop in the total number of consultations. And it's true that not only have we changed the delivery of these consultations, but the nature of what goes on in those consultations has also changed. The bottom left graph shows you the face-to-face consultations and prescribing rates from a GP visit. The red is the prescribing rates from a virtual consultation, and you can see again towards the end of the chart that signifies March-April 2020, and you can see the increase in prescriptions from each virtual visit as opposed to face-to-face visits. And another important change, if you look at the bottom right graph, you can see face-to-face repeat appointments and face-to-face discharges from hospital, but the most notable point is that there are more follow-up appointments made with digital or remote consultations, and fewer patients are discharged from follow-up with remote consultations. And that may be for a number of reasons. It may be because of the nature of the consultation, we don't feel we have sufficient information, or it may be that the case mix of the patients we see in these virtual consultations, especially at the height of the pandemic, changed, and so there were more acute patients with serious problems. And we've moved into the virtual world. On the left is a picture of a virtual ward used to manage COVID patients. I'm sure you may well have been involved in managing patients in virtual wards at home, either from the basis of primary care or from secondary care. And here, this allowed some patients with mild to moderate COVID to be managed at home. It allowed and facilitated early discharge from hospital for other patients, with monitoring of the patients with oximetry, with questionnaires, with telephone consultation, and really crucially an algorithm to identify people who are running into problems who need escalation of care. And later this morning we'll be looking at this virtual ward system in more detail. It's relevant too to other patients. So in our non-COVID patients, it may well be relevant to the management of acute exacerbations of COPD, to facilitate early discharge, for post-operative care. And also we have another session looking at virtual monitoring to assess patients in clinical trials to reduce the number of visits that they have to make to hospital. And we'll show what has gone on in the virtual world in a number of countries. That's just an example in France, the COVID-on project. Now, we're all aware of the huge number of wearables and apps. We probably use them ourselves, and our patients are using them. We're going to touch on this in cardiology and later on in a session devoted to wearables and apps this morning. There are issues with these. We need to evaluate them and understand what information they're telling us. And also, we need to integrate the information from the apps into the electronic patient record, so that data is available to the whole of the medical team and is available to the patient too, so we can practice shared care. And there's some further examples of sleep monitoring app, and also telemonitoring, which we've been doing for a long time now, over a decade, in some patients with chronic respiratory problems, sleep apnea patients on CPAP, and this is an example of telemonitoring in a patient on home ventilation. Now, artificial intelligence, use of big data is clearly a huge data too. There are many pros associated with this, but a number of cons as well. I think we've found out to our chagrin at least a few years ago that algorithms were better at interpreting pulmonary function data than clinicians were, we were ourselves. And on the left here you can see a very recent publication in the European Respiratory Journal of the use of a machine learning algorithm to help diagnose from radiology, from a chest x-ray, 10 common respiratory conditions such as pneumothorax, pleural effusion, pulmonary fibrosis, cardiomegaly. And this technique, which was developed, validated in another group of patients and then put into practice, showed two things. When the radiologists were able to use this algorithm, they made more accurate diagnoses. And secondly, they were more efficient at making the diagnosis, so the use of this extra information enabled them to speed up their care. But as I've listed on the other side, there are plenty of problems associated with this. We're going to talk about some of these issues with biases and artificial intelligence data. If they're incorporated when the data is loaded, you will have a biased algorithm. And we have a speaker tomorrow who will be talking about human in the loop, so integrating the human experience to make sure there is some kind of counterbalance to these errors. But there is the whole data issue as well, data security and privacy, and also massive problems with data hacking and cybersecurity. Only in the last few days there's been a huge ransomware attack in the US, and a few weeks prior to that there was a ransomware attack to the health service in Ireland, which considerably disrupted a number of hospital processes. And then who owns the data? It's really valuable, and we have to safeguard it being lost to private sources and so forth. So what about the global relevance? Well, the EU data space is a big issue, and regulation. How can we simplify regulation so that data is allowed to flow across cross-border barriers? How can we use metadata to keep important data within individual hospital sites, and what are the best ways forward there? And we will touch on real-time data. The chief scientist in the UK, when asked what would be the one thing that would have helped him better manage the pandemic, said real-time data. And we'll be talking to the ECDC about their generation of surveillance data. We'll also be hearing from the European Medicines Agency on their vast pharmacovigilance database, and machine learning algorithms enabled them and will enable them in future to pick up adverse effects, such as from vaccines, and to, for example, identify TTS, the thrombosis or thrombocytopenia syndrome associated with the AZ vaccine and the Johnson & Johnson vaccine. And then we'll be touching on issues with, I put here digital inclusion, as I prefer that term to digital exclusion, but we have to make sure everyone is embraced by these resources. And to that end, we will talk about digital approaches in low resource settings. And I've put an example there. This is digital resources used to manage TB patients. And the examples are the use of video observed therapy, point of care testing with diagnostics, also tracing patients, contact tracing apps, and alerting people to their exposure risk. Now, finally, I want to mention this really important topic of digital exceptionalism, as this is something we really should avoid. We would never start using a medication, a therapy, if it hadn't been appropriately evaluated in randomized controlled trials. We wouldn't introduce a new surgical procedure if it hadn't been properly evaluated. So why are we letting apps flood onto the market and a whole range of other resources flood onto the market without proper evaluation? And that's why the last sentence there in that editorial I think is important, saying continuing to argue for digital exceptionalism and failing to robustly evaluate digital health interventions presents the greatest risk for patients and health systems. And so I really hope we will cover all those areas today and tomorrow. Just before we move onwards, I think we have the result of a poll asking what you expected from this conference. Lots of things you expected, but I see the key thing is learn the latest application of digital tools in the respiratory field. But many of the other topics were important too, so we'll try and cover them all. So with that, what I would like to do is move on to our next speaker, and it gives me great pleasure to introduce Professor Terry Trusters. He's the past president of the European Respiratory Society. He did amazing things last year in enabling our transition to the virtual world with our education resources and our Congress, and has been a terrific support to me. And Terry is now going to give his reflections on the digital world too. Thank you, Terry.
Thanks very much, Anita, for this very kind introduction. If I could have my slides, then when I think about digital health or digital medicine, then I think about these topics: patient care, diagnostic support, data-driven healthcare, and digital education. Patient care, where we as professionals can be closer to our patients by being remote and use teleconsultations to see perhaps our patients more frequently. We can telemonitor our patients, for example, and also enable home-based rehabilitation, bringing rehabilitation to the living room of a patient rather than to bring the patient to a rehabilitation facility. And Professor Singh will discuss this with you in just a few moments. Diagnostic support in providing less biased and supported by evidence-based decision trees, or use artificial intelligence aids in the interpretation of multidimensional or multi-layered test results of a single patient, and where we can perhaps diagnose exacerbations remotely from out of our offices. We can also use data-driven healthcare by bringing clinical trials in phase 3 and 4, for example, bringing them closer to the patient and do them partly remotely. We can use registries, and Anita already alluded to that, but also use simple tools like electronic prescriptions, for example, that sort of digitalize the processes around healthcare that patients are involved in. And this will allow us to take more proactive decisions if we get patients' data closer to where the epidemiologists are. And I think Anita already discussed that this would have been a great asset in managing the COVID pandemic. It will also allow us to do trend analysis on things that we see happening in society around healthcare and take more proactive decisions there. Of course, as the past president of the European Respiratory Society, I also see great value in digital education, not only for healthcare professionals, but also for our patients. For healthcare professionals, I think we could bring evidence-based medicine to virtual environments where they can then practice these evidence-based theoretical concepts into an environment that sort of remembers them of where their patients are. We can also keep our clinicians more up to date, but also inform patients properly by using virtual or digital ways to be more familiarized with their conditions. Of course, there are a number of challenges, and they are on the radar also of regulators. And I think Anita already touched on some of them: data security, privacy of patients, of course, which is really important. Technical issues that patients will need to learn to deal with if they're using virtual applications or technology in managing their healthcare, but also the quality of data. And that's something that is dear to my heart. When you get data, are they of sufficient quality to allow for decisions around health? Of course, we also will have to learn and connect with different stakeholders. For example, the technology companies and also digital technology providers, multinationals, and how we talk with them, I think, is new to healthcare providers in particular. The main issue from where I stand is the rapidly changing landscape, however, and I think this is really a challenge. And if we want to make digital healthcare a success, then I think our solutions need to stand to what I would call the Lego test. I have a 9-year-old now at home, and so I'm very, very familiar with Lego, and I think it sort of shows very clearly how a digital solution should be. With these toys, the Lego toys, and I have no conflict of interest here, it grows with the patient. You have Lego for 4-year-old, for 6-year-old, 10-year-old, 12-year-old, even for adults, as you move from left to right on this slide. And so this is also the digital solution for a patient in the beginning of his disease, more advanced disease, or very severe disease. But it always uses the same platform. The patient doesn't need to learn a different toy, so to speak. You also in Lego have different solutions for different problems, and you can call that different diseases. You have the Star Wars Lego or the Friends Lego, call this diabetes or COPD, but always the patient recognizes what type of interface it is, and these bricks fit on each other, and this is particularly helpful for patients with comorbidities. And on the far right-hand side of this slide, this is perhaps the most important part. This is a house in Lego that I built together with my son using my 30-year-old bricks and his brand new bricks, and they still fit one on the other. And I think this is also important when we're talking about healthcare. We're not talking about the health in a patient from today to tomorrow, but that patient will be ill probably for many years to come. And so if interfaces change all the time, this creates a lot of stress around the patient that is not needed. And I think we need platforms that are robust and sustainable over many years so that we can take proper care of our patients. Of course, these are some more philosophical thoughts of myself, but I think they are important if we want to make digital health a true success. So with that, I will conclude my opening remarks. I hope you will enjoy this virtual summit, this virtual presidential summit. Anita, I wish you much success with it. And now we'll enjoy a very short clip showing the best of the European Respiratory Society and how it can help you make your patients better. Thanks a lot.
Thanks very much, Terry. We now move to our keynote address. At the ERS, we're always keen to learn from other stakeholders, from leaders in the field, and I think everyone will probably recognise that of all the specialties, cardiology has been a leader in developing digital resources. And to that end, we have a cardiology-flavoured keynote address. Who better to deliver it than Professor Martin Cowie, He is the chair of the Digital Committee at the European Society of Cardiology. He's a consultant cardiologist at Royal Brompton Hospital, and he has an academic base at King's College Hospital and Imperial College. And he's done many trials and has been involved extensively in research on digital telemonitoring, a whole range of digital processes. So he's going to speak on creating a realistic digital roadmap, lessons learned from cardiology. Welcome, Martin.
Thanks so much, Anita. It's a great pleasure to come to your ERS, your first digital summit, and I can understand all of the issues that you're facing as a society, and hopefully, as I share the roadmap that we've been through in the last 2 or 3 years only at the ESC, you'll find useful lessons that can transfer across. In addition to being chair of the Digital Health Committee, I was also a non-executive director of NICE for 4 years, so also have some insight into the reimbursement issues of digital technology, and we may well come back to that in the question times. There are so many different stakeholders involved in this digital redesign of the current situation as well as the future. Now, just a few words about the European Society of Cardiology to show you that it's very, very similar to the ERS and the same issues that we're facing. So we're an independent non-profit organisation that represents cardiologists across actually 56 countries, so a little bit wider than Europe strictly defined. And within that community, there are many different subspecialties which vary tremendously from very general medical, such as heart failure, down to very procedure-based and data-based subspecialties. So it's quite a broad church, as it is in respiratory medicine. Obviously, our mission is to fight cardiovascular disease, just as yours is to fight respiratory disease, and that's really what drives us. The question we ask is, does this make a difference? It's meaningful in terms of prevention or treatment of cardiovascular conditions. And it's about supporting our members. And I think in the digital sphere, it's extremely important to understand what people are looking for. So I saw you were doing some polls in this digital summit. And I think that's an excellent way of connecting with your members, not just the enthusiasts about digital technology, but the main body of people that want to know sufficient to use these tools in their daily practice when it's appropriate and when there is good evidence that it makes a meaningful difference. Just as we've had a huge transformation in terms of our educational offering, and we certainly haven't seen our large congresses that we used to do. So that has transformed the way that we think about using technology to support lifelong learning, and I'm sure we'll come back to that in our discussion. Real-world data collection, very important, and we've seen that with the COVID pandemic, not just for respiratory aspects, but also cardiovascular aspects of COVID and the vaccination programs. So very much getting involved in the business of collecting relevant healthcare data. How can we do it efficiently, just once, and use the data very quickly, but not over-interpreting the situation? And finally, we advocate for heart health, particularly at the EU level. And that's usually important in the digital conversation, where there are big tech companies, where there's regulators, reimbursement authorities, clinicians, patients, etc., and a more public aspects to this, with lots of data regulation and other legislation that's very important in this sphere. So I think it's really important that we as healthcare professionals stand up and say it's legitimate for us to be a key stakeholder in this process, that we do not want to be excluded. We don't want just to be shown new toys that have been developed. We want to be part of this co-design journey that you mentioned, Anita. So digital actually isn't the future. Digital is now and is in every aspect of our lives, including healthcare, and whether it's professional to professional in terms of our communication platforms, but also patients with each other. So there are many digital platforms that patients will use to seek information and may actually seek to interact with you as a healthcare professional. And the organizations we work in, of course, are largely digital as well. So in this report from KPMG, they said that digital is the new normal. And I think we have to realize that. There's no point fighting against this. This is part of modern society. So let's move forward with enthusiasm, but as physicians saying we want to see the evidence, we want to help collect the evidence, and where there is good evidence of clinical improvement and at reasonable value for money, we will embrace these technologies. But if there isn't, then we don't just get taken in by shiny new toys. So what did we do at the ESC? So it's been quite a short journey. So I think, if anything, we're only a few months ahead of where you're going, and I think you're rapidly catching up, which is great. But in 2016, a group of us sat down and thought about this digital landscape and also challenged ourselves, saying, why is the physician voice not really being heard here? And we identified the various different domains of digital, or e-health as it was called at that stage. And many of these aspects are already part of day-to-day practice, such as electronic medical records and e-prescribing, telemedicine, telecare, obviously accelerated by COVID. And then we have decision support, increasingly machine learning, but it can be just simple algorithms. And the wearables, the mHealth, is a very rapidly developing field with many different technologies trying to force their way into that space, and I'm sure we'll come back to that. So we kind of mapped out the different areas, and we thought we should get involved in this, and we were thinking about how would we meaningfully engage with the stakeholders, how would we meaningfully engage with patients and the public about these issues, and develop co-design of the future within cardiovascular disease. And then came along COVID-19, of course, and that really has caused this tech acceleration, where overnight 99% of my consultations, for example, in a busy heart failure clinic, went from face-to-face to remote. And this, of course, was challenging, but now we've learned a lot about what to do and what not to do. It's also been challenging for our patients and their families, but surprisingly, of course, we've all had to cope because of this emergency. But you can see telemedicine becoming mainstream. You can see digital health, which is truly a global phenomenon, and it's very important not to forget that actually it's had a huge impact in less wealthy countries, not just in Europe. The apps and wearables are really challenging us about the regulatory perspectives. What is a good app? How do we know when a patient thrusts their smartphone at us and says, have a look at this, doctor? Do we know whether it's reliable and valid data? Should we use it for our decision making? What if we ignore the data? All of these consequences have had to be worked through really quite quickly during the pandemic. But I don't need to remind you that digital is here for all of us, all of the time. Remote consultation and also remote monitoring, which is a different concept, where you collect physiological data, usually from the patient at home, and remotely you can help advise them either about lifestyle or changes to their medications or treatments, or schedule visits that might be appropriate face-to-face. So using these tools to support the delivery of healthcare and trying to optimize the outcome for our patients, but also the experience of care, and realizing that one size does not fit all. So it's very important to have a suite of things that can be offered where appropriate. But the future is very bright, and there's many people very excited and a lot of money going into this area. And I've just put some pictures up here to show you about drones delivering medication just in time, or defibrillators if there's an out-of-hospital sudden cardiac arrest. And we can now collect heart sound information and analyze it, transmit it anywhere. Echoes can be done by robots using artificial intelligence to get the best images that can be interpreted anywhere in the world. And in effect, it's democratization, where it doesn't matter where you live, in theory at least, you should be, with these digital tools, able to access state-of-the-art diagnostic facilities and also decision support for your choices about your health care. So everything is changing with lots of potential. Some of these things will last, some of them will be fashionable and disappear. How do we navigate through this space? And that's where I think the dialogue between the ESC and the ERS, I think, will be very helpful for patients with comorbidities, with breathlessness, for example. But ultimately, we may end up with almost continuous taking of the temperature of our patients in a broad sense, a digital fingerprint of what's going on, their activity, their quality of life, their cardiovascular variables, their sleep quality. All of these issues could be there, sampled almost continuously. Question is, the challenge is not so much about collecting data, but making sense of data and making sure you're making better decisions, not just more decisions. And how does this play out in a tightly regulated environment where people are very risk averse, which is quite right as a physician, but sometimes slow to change practice? Of course, intelligence has to be good, and I'm quite happy with human intelligence most of the time, but we can supplement that with artificial intelligence. With the volume and the velocity of data, it's impossible to analyze it ourselves. Also, our patients are much more complex, many more data streams, so putting this all together and making it simple for us as physicians and our patients to make the best decisions is, I think, going to be the trick. There's a lot of hype, and I think the danger is that people that are super excited about digital all speak to each other, and people that are not at all into this also speak to each other, but they're two separate groups. And I think what's very important for a professional organization is to have the conversation in the same room. So you have the technologists, you have the physicians, you have the patients, you have the reimbursement authorities, the regulators, the policymakers. Let's create this future together. And just a very quick example in cardiology, this is a heat map in the center of the different disciplines and the different techniques and where artificial intelligence is most being used. And cardiology is largely about pattern recognition, about interpretation of signals, whether they be ECG signals or imaging signals or complex streams of physiological data. And you can see for arrhythmia, for imaging, echo, MRI, CT, that's already part of the new normal in terms of machine learning. Other areas, slower to move into this space, but it's about better and more efficient diagnosis. It's also about new classifications of disease, so a more intelligent way of splitting phenotypes into things that might lead to developments in therapy. It's also about prediction of the future and risk stratification, and we can improve on that. Sometimes the old ways are still just as good, and machine learning has a little extra to offer, but quite often there is at least an incremental benefit from doing this. These are some of the devices that are already approved by the FDA, for example, in interpretation of ECG data or imaging data. So we mustn't view all of these digital things as science fiction or Star Trek or in the future. These are now and are happening already in many disciplines and have a lot to add. I think the challenge for many is that they feel that their role will be taken away by artificial intelligence. But I think what will happen is those that use artificial intelligence will be more successful, and those that don't, they may well be replaced. But the role of the physician, the role of the person to put the information together, to take responsibility, to explain the rationale to the individual with the condition, and to make a plan and to have empathy will always be there. But perhaps we should be ending up working at the top level of our competencies rather than, as we do at the moment, often at the bottom level, doing tasks that are actually better done by machines. So a few examples here of where AI is already being used in terms of scheduling of appointments, which is quite complex when you've got multiple scans as well, about looking at social media for early indications of problems, about putting together in critically ill patients signals of deterioration well before they would be picked up normally, and about better risk quantification. So all of these things are really integral to the role of physicians and teams working in healthcare. And this is going to be changed, already started to change, and we need to be part of this. Of course, there are concerns, so I don't want to come across as a digital enthusiast without some realism here. There are concerns about if you use the wrong data sets, or they're very limited and they're not validated, then you may actually be introducing biases which could be powerfully harmful to others. What about data privacy, which in Europe is a very key concern for obvious reasons? And then also, what happens to you if you make a decision based on some of these results. What happens if something goes wrong, which it will do from time to time? Where's the liability? How can you defend yourself? How can you even explain why you've arriven at the decision? So just in the last minute or two, let me just give a little bit more detail of the roadmap of the ERC, and then we can have a discussion about the ERS and where it might be going. So 2016, we produced the first kind of roadmap for that, but that was very top level and lacked detail or a clear way and mechanism of delivering that. We then decided we had to set up an overarching or transversal committee, the Digital Health Committee, and this was looking across the whole family of the European Society of Cardiology, all of the sub-disciplines, and trying to coordinate the activity and make sure that it wasn't just Brownian motion or osmosis, but actually a strategic thrust forward into this area. Education obviously is hugely important for a professional medical organisation, so making sure our conferences and education matches the needs, the educational needs and lifelong learning needs of our members across very varied countries, very varied amount of income that goes into healthcare, and also digital readiness. We also wanted to support implementation where there was good evidence of benefit, so physicians not seen as blockers of advancement and change of ways of things, of doing things, but actually could be facilitators where the evidence was there. Advocating, though, for standards, for best practice, for support for people, for evidence requirements for this. And that's been an interesting journey, and from the NICE perspective, I've seen it from the gateway to reimbursement. What is sufficient evidence? Digital exceptionalism that Professor Simons mentioned, just because it's new and shiny and digital doesn't necessarily mean it's better. Should we fund this? Should we not? What's the evidence? Is there harm? All of these issues are being worked through by the regulators, by reimbursement authorities, by the policymakers. But the general push is that we can do things better, more efficiently, and COVID has accelerated the acceptability of that. And key to all of that is to map your stakeholders in this process and to get them together to try and find a common language about what the future might look like and help to co-design that. The ERC is increasingly moving into research across cardiovascular disease rather than just education and advocacy. And this is where real-world evidence, big data, data standards, etc., is hugely important. So there are quite a few projects funded by the EU and other organisations to help drive that forward. But ultimately, for me as the chair of the Digital Health Committee, it's about what do cardiologists expect the ESC to deliver. So we did a survey across our members just very recently. We've published it in our new journal, European Heart Journal Digital Health, hint, hint, for the European Respiratory Journal. And you can see that actually for our members, the vast majority at best have a fair knowledge of digital health. Very, very few actually know very much about it or have really committed to learning more about it and thinking about how to change their practice. The familiarity is greatest with clinical information systems, electronic medical records, e-prescribing, where there's huge familiarity. That's part of normal practice. Telemedicine and telecare, a little bit more familiarity, and certainly COVID's accelerated that. But when it comes to apps, wearables, personalised health, very little knowledge of this, a lot of concerns about this, and almost in a way heads in the sands. Let's not talk about this, it's too difficult, let's park it for another day. And that's one area that we're certainly exploring very actively at the moment. What should the ESC do about recommending apps, for example, or how can they signpost to resources? So you stop having this kind of blocked conversation, the patient coming in with their smartphone and you saying, no, I'm the doctor, I'll only use the data I collect, I'm not interested in what you've got. And that really then doesn't create a great atmosphere for shared decision making. How can we improve that? How can we prescribe apps, for example? How do we know that they're useful and safe? So we've also thought about some of the barriers and solutions to this in this complex, highly regulated environment. Here's a paper just published a year or 18 months ago where we plotted this out, and there are lots of barriers, and physicians are very good at thinking about the barriers and giving long lists of them, so I'm not going to concentrate so much on that. That's on the left-hand side. But lots of solutions, and it is about having a conversation with the stakeholders. It's about education and lifelong learning, but it's also having the ability to identify something with huge potential and trying to accelerate it through into the real-world practice. But on the left-hand side, under the picture of a notional patient, this is just showing a health literacy, never mind digital literacy, a survey done across Europe, and actually half of our population in Europe has insufficient or problematic health literacy. When you move into digital literacy, it's even worse. Many of physicians are not very digitally literate, some are hugely, but the problem with our patients is often worse. So we have to think about how do we develop tools that meet our needs, a flexible range of solutions, and not excluding people if they don't wish to have that type of support. So as we move out of COVID pandemic, hopefully, I think in my service and across cardiology, we will offer a blended option of different tools to support different needs. But the general direction of travel is more remote access to care and decision making. Ultimately, you as an individual living with your cardiovascular disease will use the tools that are available to support yourself in maintaining your health, but also those tools will help you access healthcare and more professional support when you need it, but only when you need it, and rapidly and efficiently. That's the dream of the future, and I think that is realizable in many countries within the next 5 years. The other things we've done, just to give you a little snapshot, we created a summit, just as you've done. This was in Tallinn, one of the most digitally literate countries in Europe, Estonia. And we had a fantastic time there, bringing together the technology experts, the small startups, the regulators, the physicians, the patients, roundtable discussions. Who knew that we could actually all have a conversation in the same room? We then decided to launch our new journal, European Heart Journal Digital Health. We're now just about to put our 3rd edition to press. It's already on PubMed. We've already got some of the world's top digital papers in cardiovascular disease, so enormously successful. We've also had a Digital Health Week last year, and this year, and you're very welcome to come to it, it'll be virtual, is the ESC Digital Summit, where we have the European Space Agency, medical futurists, but also practicing cardiologists telling us about some of the opportunities and challenges there. So this education theme, normalizing digital, having a conversation all together, and then demonstrating to the world that cardiologists are a legitimate part of this discussion is one of our aims. We've also produced documentaries, a television style thing, and streamed those out. So devices and mobile applications, AI and big data, telemonitoring, teleconsultations, some examples, bringing together everybody to give their perspective on these issues. I've mentioned European Journal on Digital Health. Have a look at that. We're very pleased with that, and it seems to be a vehicle to crystallize some of the activity and interest and enthusiasm in this space. Advocacy, very important, and I know the UK's left the EU, but the ERC is much broader than just any political organisation. So we try and advocate for this, about standards, about implementation, about learning, etc. Not overdoing the regulation, but also wanting the evidence to support best practice. As I've said, my key message here from the Digital Health Committee within my organisation has been about having the conversation, making sure that silence is not taken as assent to the issues, but actually bottoming out some of these key issues and exploring them and coming up with white papers, coming up with directions of travel for this, and making sure that it is indeed co-designed. So I finished with this little cartoon or picture. The future is not something passive that we're just moving towards. The future is something that we can co-create. So I'd really encourage more dialogue, and thank you very much for asking me to come along and compare and contrast with where you're going at ERS with what we've done at the ESC. Thank you so much.
Martin, thank you. That was truly excellent. There was lots for us to learn. I loved your allusion to Brownian motion. That's something we definitely want to avoid doing. And talking about the stakeholders too, and we have involvement from our European Lung Foundation, patient groups who will be presenting on digital exclusion and real world learning, and that's something that we have to do this in partnership. I wanted to pick up on the theme, and that is the realism and the futurism, and understand, because we've got a lot in common with our patients. Our chronic respiratory patients, chronic heart failure patients are very similar. Many of our patients have cardiorespiratory comorbidities. And so just in the real world, tomorrow in your heart failure clinic, what kind of digital resources would you be using now?
So what we do now, and some of it of course is a little bit trial based and others are actually into practice. So obviously doing remote consultation is a norm, and that can be telephone or it can be video. Occasionally it has to be face to face, because as you know, very complex patient, and you've never met them before, complex family dynamics. There's nothing like sitting there with them and understanding what's happening. So that's why I emphasize a blended approach. It's not digital or, it's digital with all of these. It should be just seen as part of the normal suite of things that we need to do, but to do well. So we have to learn the skills of doing remote consultation. But then signposting people to resources, say there's a good website, send them the link by SMS, for example. We also have developed an avatar, which is a friendly person explaining, you've seen the doctor, they mentioned these things, let me chat to you more about it. So in their own homes, on their smartphone or their iPad, they can then click on the link, and the lovely avatar goes through a lot of the information, and it's less medicalized. It's more like a chat with an older friend. So those are the tools that we're already using. And then of course, in cardiology, we have many implantable devices. So as you know, for many of the patients we've shared, they often have a defibrillator or a CRT platform. Continuous streams of physiological information. We can even see how much sleep apnea they're having. We can see the heart rate variability. We can see the lung water. But as you know, the challenge is to convert all of those data into sense and making better decisions, and that's been quite challenging. So you're right, I'm not wildly enthusiastic about everything digital. It has to find its place, and we have to find the evidence.
Understood. And that's the digital realism. We were talking earlier about futurism, and you even are going to invite a futurist to one of your congresses. And therefore I wondered how you would see things, say, in 5 years' time in the clinic, or even 10 years' time. It's hard to predict what's happening next month, but I wonder if you'd care to speculate.
Well, you know, COVID has had the positive impact, looking for the silver lining there in accelerating, as we've said. A lot of the things that were gradually changing in practice have suddenly overnight changed. And for me, it's a message of hope that humans are very adaptable. Where they see the need, they will use the tools that are there, and they will try and optimize them and learn. And I hope that we don't lose that agility and imagination that COVID has forced us. We need to make sure we don't just settle back into kind of slow and clunky iterative change, but sitting down half an hour once a month and saying, okay, let's imagine the future in my service or in my hospital. How can it look different? And then always, I think, thinking about the patient experience. And as one gets older, of course, one has more experience oneself of that. It is actually the experience of care is almost as important as the care. And that, I think, is something we can do a lot better, and digital can help support that, make it more efficient, more streamlined, more responsive. So let's not just say, oh, well, it'd be nice to have. Let's make it happen. And that requires a lot of energy and enthusiasm, and keep pushing and resilience to say this is possible, let's do it.
Got it. And I'd just encourage the audience to ask questions. We're very lucky to have Professor Cowie with us to answer them, so please post them along the bottom of your screen. In the meantime, I have lots of questions too. And one of them is that we have talked about patient engagement and the fact that this has to be a joint project, and we'll come back to that area. But there's also team engagement as well. And you mentioned that there are digital enthusiasts, and I'm sure there are amongst respiratory team members, but there are also some resistance in other team members, and how you've kind of worked to engage everyone in the project.
Yes, that's a very good point. And for example, heart failure patients with CRT or ICD, you have the pacing technologists that used to work in the pacing clinic and just their world. You had the heart failure nurses in their world. You had the cardiologists in their world. Bringing them together and saying, okay, these are the things that we could do. It's feasible, technically feasible. Shall we try and explore it, whether it's worthwhile? And working through the workflow, what happens if, together as a team, and then saying, let's try it for 3 to 4 months. Now, if it doesn't work, we'll stop doing it. If it does work, we'll then try and improve it further. But this kind of cycle of it's all right to fail, it's all right to try and fail, but you have to move things forward. And I think a lot of this, as you know, Anita, you're very good at this, is actually listening rather than always speaking. So actually asking open questions and hearing the other person's perspective, which often comes back as anxieties, concerns, workload issues, etc. So one has to understand that whole team dynamic and then have the enthusiasm to keep people going until they see the value. And then often the people that were most resistant become the most enthusiastic when they see the benefits for the patients and themselves.
Right, so I mean, this is part of managing change,
Yes.
but it's a rather continued cycle of change. So that's within the cardiology team, and then we have separate issues, all of us, whether we're in primary care, secondary care or tertiary care, in embedding this within the institution, working with managers and working with reimbursement. One example is that it's quite difficult sometimes for telemonitoring to be reimbursed, although a lot of time can be spent on it, contacting patients, they're not there, they have to be recontacted. And that was part of your roadmap. It's different in different countries, different health services, but is there some kind of message you can give us about embracing the wider sphere of health services?
Yeah, reimbursement always trails behind the leading edge of anything. And I think it's about understanding what reimbursement authorities are looking for. So professional societies, ERS, ESC, can work to make sure that if there's something that looks promising, let's do a proper trial, adequately sized, rapidly. And I'm not saying it always has to be 5,000 patients in a randomized trial, but let's do the evidence collection. Let's get the evidence together to show the clinical impact and the value for money proposition. And then if we can do it more rapidly in partnership, then they will line up behind it. I think the problem is that too many clinicians think this is a nice new toy, I'll just throw it at people and they will like it. And of course that's not the way it works. But I think to the question of tools and comorbidity, I see there's a question coming in on comorbidity. There's no reason now with remote consultation why you and I can't consult with the same patient at the same time. And I think pulling in those resources, and the patient can be somewhere, the children or grandchildren somewhere else, the specialist, that requires a lot of organization. That's where AI can help us. But that would mean that you as an individual get the input just once from people talking together rather than being fired into separate clinics, the cardiac clinic, the respiratory clinic. It doesn't make much sense in a modern world. So lots of change there, and I think maybe ERS and ESC should work together on some pilot projects there.
Well, yes, and in fact there's a question from Monica Fletcher here about joining up respiratory and cardiovascular disease patients with comorbidities and societies working together, so I think that makes the point.
Yeah.
Another nice comment on a great and visionary presentation, which is good. Just a question, because we're running slightly over time, but this is good value discussion, I think. Remote cardiorespiratory auscultation. What do you think?
Well, as a cardiologist, I love my stethoscope. It's a badge of honor. And I do listen to every patient because they expect it and it has healing qualities. But to be honest, with echocardiography and other information, you probably can get more information from the imaging. There is additional information, however, from the auditory signal. Even the voice can give you information about fluid in the lung and the heart failure status. So there is something there, and patients can now just record their heart sounds, send an audio file to you, and you can listen to it. So there is something in there, but at the moment it's a little bit gimmicky. And it's not really fed into decision support. But watch this space. Audio signal interpretation has got something, I really do feel.
Okay.
But don't take away my stethoscope.
No, all right. So something in the near future.
Yeah.
Well, that's totally brilliant. We've been really lucky to have you come and give our keynote address. I'd like to thank you, and we'll move on to our next session now. Thank you, Martin.
Pleasure.